So let's talk about looking at masked results. Masked results give you more valid and complete ear-specific information about pure tone thresholds, speech thresholds, and word repetition ability. You should know there is a central masking effect, which essentially means even if crossover is not happening, even if the original threshold that you obtained was from the test ear, when you add masking into the mix, it distracts and it utilizes some of your auditory resources. So sometimes you can see a threshold shift of 5 dB even if the original threshold was actually from the test ear. Related to that, there are some people, when you put masking in the opposite ear for speech, whose speech scores are just get much poorer. And whether that's because you're ensuring it comes only from the test ear, or because the noise is actually having a negative effect on their auditory processing, can be difficult to tease apart sometimes. So here's an example of an audiogram. So you've got normal hearing in the left ear, and then you've got this low frequency hearing loss in the right ear. So if we did bone conduction testing, and we put the bone oscillator on the right side of the head, but remember, this is unmasked bone, so unmasked bone should always be read as best bone. We don't know if this is a conductive hearing loss in the right ear, or if this is sensory neural loss in the right ear, because all we have here is best bone, and best bone lines up with the better hearing ear. So, masked bone is necessary in this case. And the picture that masked bone presents can really substantially change sort of the diagnosis and the recommendation. So here's an example. If masked bone were down here, this is a low frequency sensory neural hearing loss, and there are very few pathologies that will cause a low frequency sensory neural hearing loss. One of them is Meniere's disease. So this is what an audiogram might look like for unilateral Meniere's disease. Meniere's disease is one of the only things that causes a unilateral low frequency sensory neural hearing loss. And so recommendations for this, and even case history questions related to this, are going to be different. So if there was a patient that I suspected Meniere's disease, I would want to ask several times and in different ways, are you hearing any roaring or rushing sounds, or sounds like the ocean in your head? Because the hallmarks of Meniere's disease are low frequency sensory neural hearing loss, or fluctuating low frequency sensory neural hearing loss, rushing or roaring tinnitus, and episodic dizziness or vertigo. However, if these were your masked bone conduction results, then what you have is a conductive hearing loss in the low frequencies, and then you're looking more at an eardrum problem or potentially fluid in the middle ear space, so an otitis media type of problem. And this is absolutely a very common audiogram for young children that might have an ear infection. So this conductive low frequency hearing loss is actually much more common. Conductive frequencies by their nature are conductive hearing losses by their nature are typically low frequency. So this is a much different audiogram, and it's really only the masked bone that changed from this to the potential Meniere's disease. It can also make a huge difference in speech masking. Let's say you had a patient with a unilateral hearing loss, and the SRT in the left ear is 10, SRT in the right ear is 55. You tested word rec. Word rec is great in the normal hearing ear. You test word rec at 95 in the right ear, and they get 100% unmasked. Super! But depending on which transducer you're using, you either have essentially 25 dB of crossover, or Sorry, I'm trying to do math in my head. 45 dB of crossover, because if you were using phones at 95 dB, you're going to have 40 dB of intraoral attenuation. So it's going to be actually crossing over to the left ear at an intensity of 55. And you already know their word rec at 55 in the good ear is great. Even if it were phones at 95 with the intraoral attenuation value of 60, or even 65, you're going to be crossing over at about 30 dB, and that might still be intense enough for them to actually get some use out of their left ear. So, masked, you might see that excellent word recognition score in the hearing loss ear drop substantially from 100% to 58%. And that's why masking for speech is really so important, because now you have something else to consider if the patient is going to be a candidate for amplification or something along those lines. This is a great audiogram. This audiogram is showing you a really important concept in masking. So none of the thresholds are masked. You can tell because the unmasked symbols are used. And what you see, and you can look at an audiogram like this and figure out what transducer was used. This thing at the bottom is what's called a shadow curve. And the shadow curve is the responses that are the result of crossover. If you look at the difference between the thresholds for the right ear versus the left ear, they are about 60 to 70 dB apart across the board, and they're the same across the board. So I would guess that inserts were used, and this line across the bottom here are not true left ear responses. They're actually the right ear responding once sound has become intense enough to cross over to the right ear. This is the audiogram you would see if somebody had a true profound sensory neural hearing loss in one ear. So if you did unmasked air conduction thresholds bilaterally in somebody with a dead ear, this is the audiogram you would see until you masked the thresholds for the poorer ear, in which case these responses would disappear. So this is the shadow curve along the bottom. And it's important for several reasons, which we'll talk about in a minute. So here's another audiogram. Again, let's assume the bone symbols correspond to what side of the head you put it on. So look at this audiogram, and a couple of things should jump out at you. First, if you did unmasked bone on the left side of the head, and then you did unmasked bone again, bone oscillator on the right side of the head, the red unmasked bone scores would be essentially the same. They might be a little different, maybe 5 or 10 dB of intraoral attenuation, but for the most part, unmasked bone is always best bone, so these unmasked right ear bone scores should be way up around 10 dB. The fact that they're not is problematic and tells you the person is not being honest about what it is that they're hearing. Same thing for the bottom. This is a person who came in and didn't respond at all when the right ear was stimulated. But now you know, no matter what transducer you're using, if the person really and truly had a dead ear, after, 60, 70 dB of intraoral attenuation if you were using inserts, less than that if you were using headphones, the person would eventually be, as the sound became more and more intense in the right ear, the person would eventually hear it in their left ear. So this, with nothing masked, this is not a viable audiogram. The person is not being honest about their right ear hearing here. There should be a shadow curve on this audiogram, and there is not. Same thing here, where you've actually got some responses, but they're down at profound. And this one's interesting because this one is not outside the realm of possibility. If you were using inserts where you're expecting, if you're expecting a shadow curve, as an example, to be about, 60, 65, 70 dB, you're sort of close to that. So this might actually be a shadow curve. Or they might not be honest about their hearing. So this is another case where masking is really, really important, so that you know whether or not this is a shadow curve or not a shadow curve, or whether these are actually true right ear thresholds. Bottom line, masking is hard. There are a lot of things to remember about when to mask, how to mask, and what to do with masked results. Masking is really important. It's the only way that we can ensure that we're getting true ear-specific responses. You need to know why we mask, when to mask, and how much masking to use in different clinical situations. And this is just a sample audiogram that we're going to use to do some more masking examples in class.